YouTube channel is perfect. All right. Well, welcome, and we're now recording, so we can get started. Thank you, everyone, for joining us for our 5th VT Reach session. We're so excited to have everyone here tonight. Tonight, we'll be spotlighting pathology and medical lab sciences. So joining us tonight is Dr. Wojewoda, Dr. Gibson, and Kate Moreau, and they will each be discussing their journey to where they are today, their education, and then what their daily responsibilities and things look like. And then they're going to be talking about a really interesting case study at the end. So yeah, as always, we'll have 2 Q&A sessions. The first one after each of our speakers goes through, introduces themselves and talks about themselves, and then one at the end. So feel free as the session goes to put any questions you have in the chat, and we will get to them during those Q&As. But yes, please ask as many questions as you would like. And so we will now begin with Dr. Christina Wojewoda.
Hi, everybody. I'm Christine Wojewoda. I am a pathologist, and I guess the first part is what made me interested in medicine. And really, it was my mom. She was not a doctor, but she was a medical lab scientist, which Kate is. So you'll hear a little bit about that. But I remember as a kid, she would bring me along when she was performing phlebotomy. So when she would draw people's blood, I would sit in the room and watch her. I'm sure that wouldn't fly now, but I would love watching the blood go in the tube. I was very intrigued with that. And people would look away and I would think that it was the coolest. And then she would bring me into the lab with her, and I would get to see the blood cells under the microscope and get to see what was going on in the human body. I thought that was really fun. And I was always kind of passionate about math and science throughout my junior high and high school years. This dates me a lot, but I really thought that I was going to be an ER doc because I loved watching the show ER. It was filmed in Chicago. I grew up outside of Chicago, so thought I was going to be an ER doc, live in a high rise in Chicago, be single, and have 2 big dogs. The only one of those things that is true now is I have 2 dogs. Just remember that as you go through life, your first thought, what you think you're going to go into, may or may not come true, and that's okay. I'm super happy with all of my choices. So when I went between high school and college, my mom had switched jobs and she worked at the College of American Pathologists. And that's not a school, it's a professional organization for pathologists. And they do a lot of different things that I'll talk about in a little bit. But I worked there in the summers interning, and a lot of the staff there were former medical lab scientists. And they all said that microbiology was their most fun course in medical lab sciences. And so I was lucky enough to be at the University of Wisconsin in Madison, where they had a medical microbiology and immunology program. And that's what I majored in, and figured out that I love the bugs. So the bugs are teeny tiny things that, sometimes we can see them with our naked eye. Sometimes we need to use microscopes. Sometimes they're even too small to see with routine microscopes. You need to use an electron microscope. And they constantly are evading our immune system, escaping the antibiotics that we have to treat them. And the interplay of the infections and the human was really cool to me. But after undergrad, I didn't know if I still wanted to go to medical school, if I wanted to do research, if I wanted to do both. And so I took a year off and did HIV research at the University of Wisconsin-Madison. And I learned pretty quickly that I am much more immediate gratification than research allows. Research, you have to have really amazing ideas and get funding for those ideas. And then sometimes it takes years to prove or disprove that idea. And I really liked to kind of make change faster than that. And so that's why I went to medical school. So I went kind of back closer to the home at the University of Illinois at Chicago. And I still loved the bugs, so I was deciding between internal medicine and infectious diseases, or pathology and microbiology. And I rotated in both. I still rotated in emergency medicine. I really liked emergency medicine. It fit my personality of find a problem, fix a problem, cross it off the list. But I was still intrigued by the human body and the interplay with the body and disease. I liked infectious diseases. They're some of the smartest people that I've ever worked with. But I really found that my passion and my home was with pathology. I got to know the answers first. Most of the doctors that are treating you based on a test result that they got from the laboratory. And so I kind of liked to know all of the answers first. So I went to Case Western for my residency. There are two parts of pathology that Dr. Gibson and I both represent. So I primarily do clinical pathology, and I'll talk about microbiology specifically in a minute, but clinical pathology really focuses on lab tests, usually on blood, but can also be other things. In the microbiology lab, it's often fluids and tissues. Whereas Dr. Gibson will tell you more about anatomic pathology. That's really looking at fluids and tissues to make a diagnosis. The testing that we do in the clinical laboratory can be a little bit different. But I wanted to make sure that I understood both anatomic and clinical pathology. So that's a 4-year residency. And then I went on to the Cleveland Clinic, where I did a medical microbiology fellowship. So I focused just on microbiology. And so in the microbiology lab, we basically look for all types of infections to see if you have them or you don't have them. And if you have them, sometimes how to treat them. So a simple example that a lot of you have come into contact with is strep throat. You get a throat swab. Sometimes a doctor does a test right there in the clinic, and sometimes the swab gets sent off to a laboratory for culture. Anytime a doctor thinks you might have an infection and does a test to detect that infection, they would send it to my lab. So I don't do all that testing. So my responsibilities are actually more in I oversee all of that testing. So I have about 35 people that work in the laboratory. They're medical lab scientists, and you'll hear more about that. And my job is to make sure that we are doing the best testing possible, that we get the correct results out to the clinicians. I talk to a lot of doctors all of the time about what testing should be done or shouldn't be done and how to interpret those results. And then as new infections pop up, we need to bring new testing into the laboratory, or new techniques might arise that we need to make sure that we keep up to date with. And so COVID-19 was a big example of that. So that's been my life for the past, 15 months, making sure that we have enough testing and can get results out quick enough to clinicians and patients to make sure that people are healthy and safe. But something you need to know is that we can't just buy a test off the shelf and start doing it in the laboratory. We need to make sure that that test is accurate, so that the positive results really are truly positive and the negatives are really truly negative. And so we have to do a lot of work to make sure that the test works before we report out any results. And that's some of the regulations. So the clinical laboratory the laboratory in general is very highly regulated. And that's good. We want to make sure that we're putting out accurate results that your doctor can act on and treat you appropriately. So I need to make sure that we're doing everything correctly in the laboratory. And then I get to do stuff like this and teach residents and medical students and medical lab science students. And I even sometimes teach in undergrad courses. And so being able to teach people about microbiology and kind of share what I do is always really fun. Am I allowed to take the question now, or should I wait till later?
We can do all the questions together during the Q&A session, but keep putting questions in the chat as they come up and we'll address them all.
Awesome. Some fun things I get to do outside of my my paid job is I'm extremely involved with the College of American Pathologists, and that's the organization that my mom had worked for. She's since retired. But that organization is a professional organization of pathologists, but it also helps in ensuring that laboratories stay up to date and are compliant with regulations. And that might not seem very fun, but it's actually really interesting. So I get to travel all over the country, and I've traveled all over the world going into different laboratories to make sure that they're doing testing appropriately and reporting out accurate results. Again, traveling all over the world is super fun, especially when I don't have to pay for it, but then also I get to meet experts in the field and get to learn from them as I'm inspecting their laboratory. I do that through the College of American Pathologists. I'm also the chair of the microbiology committee through CAP, and that committee helps update the regulations to keep them timely. And then we also, part of the regulations are that laboratories get sent unknowns. So just like you have unknowns in like your chemistry classes or biology classes, each laboratory is required to get unknowns sent to them and then report back the results, and they have to get those results correct. Otherwise, the laboratory could get shut down. And so we, through the College of American Pathologists, put out those unknowns to try to, one, test labs that they're doing things correctly, but also challenge them a little bit and educate them in the process. So that's been a really fun part of my job. Again, getting to work with leaders in the microbiology field and helping to move the specialty forward. Next slide. So what's my life like? I'm pretty much 8 to 5, Monday through Friday. Because microbiology is relatively small, I just, as of a year and a half ago, got a second microbiologist. So now there's 2 of us in Vermont. But previous to that, I was the only microbiologist in the state. So I would get calls from residents on evenings and weekends. I don't often have to go in. Every once in a while, I'll have to go into the hospital to take a look at something. But pretty much Monday through Friday, 8 to 5. The pandemic has taught me that I don't have to be in my office to do things like this, or, a lot of my meetings are still virtual. So I'm trying to take better care of myself and take some at-home work time as well. And because I don't have patients scheduled, my stuff is pretty flexible. So as long as I don't have a meeting scheduled, I can leave early to go exercise or go to appointments, and then I just have to make up that whatever I didn't get accomplished that day later. So it's really quite nice to kind of make my own schedule. And then this is, the picture on the left is my lab. A couple of weekends ago, we finally got to all get together outside of work. So I had everybody over we just got to relax a little bit. So these are people that work in my lab, and that's one of my dogs walking through the picture. And then I've got Cosmo and Smuckers, our 2 Weimaraners that we've rescued that keep me active and definitely are bundles of love.
Well, thank you so much, Dr. Wojewoda. That was really great to hear about. And now we are going to hear from Dr. Gibson. And so she is going to be speaking about her journey and what she does every day as well.
Thank you. Yeah, so my name is Pam Gibson, and as Christy said, I'm also a pathologist, and I do the other side, what might be considered the other side of pathology. I do what's called anatomic pathology, where I look under the microscope most of the day. I'll tell you a little bit first about how I was drawn to medicine. I think I had a lot of interest in math and science in high school and had thought maybe about being a doctor. I had was planning on being on the local ambulance squad, and I happened to go on a class trip for a marine biology class trip with our biology teacher in high school. And at the end, after that trip, she actually gave me a stethoscope as a thank you gift, because I had to, she refused to go to the emergency room, and she had gotten injured, and she only refused because we had already been to the emergency room for 4 hours because I had gotten injured. But then she got injured and got a bad scrape on her foot and full of sand. And I took hours picking the sand out of her foot. And so she gave me a stethoscope, and it was like, wow, maybe I can be a doctor. This is cool. I really like this. And I thought for sure that I would want to be a primary care doctor and see patients regularly. So after college, I went to medical school right away. I came to the University of Vermont. I had gone to a small liberal arts college in Maryland called Hood College. And when I was in medical school, I got through the basic science portion of medical school, which is about the first year and a half, and then started the clinical year, where you get to rotate through all the major specialties like medicine and surgery and OBGYN. And I started questioning whether whether medicine was right for me. Something was missing. I enjoyed meeting the patients, but I couldn't see myself doing that the rest of my life. I don't know. I realized that I was more happy when we were doing the basic science part of it, when we were doing the book learning and understanding about the basics of disease. So I decided to take a year out because I hadn't taken any time between college and medical school. I took a year to do what's called the Pathology Student Fellowship. So it's really stepping out of medical school, but I stepped into pathology. And so it was like a gap year during medical school, and got to see what pathology was all about. And I didn't know much about it. I had no idea what pathologists were. And you may be saying the same thing, like, what do you all do all day? And you get an idea now of what Christy does. And she runs part of the laboratory in the hospital where the testing gets done. But I got to see that, and I got to see what the pathologists do when they look under the microscope and make the diagnoses. So when people have biopsies or have to have a piece of their body taken out, like let's say their appendix, that's going to get sent to the laboratory and looked at by a pathologist. And there's a lot of steps in the process, but I will look at that under the microscope and make the diagnosis. The doctor will say, yes, we think the patient has appendicitis, but we will prove whether they did have appendicitis or not by looking at that under the microscope. So that's the study of diseases, pathology. And I was like, wow, this is incredible. I can have the answer. Like Christy said, I want to be the person with the answer. Before other people have the definitive answer, we can give that to them. So we're often considered the doctor's doctor because we're the ones behind the scenes that are helping provide the answers. So when I did pathology residency, after I finished, went back to medical school, went into residency, it was 5 years then, and they subsequently changed it to 4 years, but I did it quite a bit ago. And then I also did a fellowship year. Christy, you heard, did a fellowship in microbiology, I did a fellowship in what's called cytopathology, is the study of single cells. And so, not only can we take, pieces of organs, we can take biopsies, and those are kind of intact pieces of organs or whole organs out, but we can also stick needles into lumps and bumps and masses and just pull cells out, kind of like you would pull blood cells out when you had your blood drawn. But now we're pulling cells out of solid organs. So we can stick needles. I can personally see patients and can stick needles in lumps and bumps that are superficial. So I can also do ultrasound guided biopsies of, say, like the thyroid here in the neck. And then if the lump or bump is deeper in the body, say in the lung or the liver, and we need a different way to see where the needle's going, radiology, we would work with radiologists and they'll stick the needle in, but we'll be present at the patient's bedside to take the needle from them after they've put the needle into the patient's lump or bump. They take the needle out and we smear it onto slides and look at it under the microscope right there while the patient's in the room, so we can decide whether we have what we need to make the diagnosis and if there's any other testing that needs to be done. And we'll talk a little bit more about that when we talk about the case. So that's part of what I do. As an anatomic pathologist, we diagnose disease and typically under the microscope, but it also involves looking at the organs grossly. So we have to learn how normal organs will look and how tumors look to the naked eye, as well as how to take sections of them and get them processed for making them into slides. As part of that, I have a specialty in kidney pathology. So I look at kidney biopsies when people have kidney disease, and I'm the only doctor in the state that looks at those kidney biopsies. And I work with the doctors that take care of the patients with kidney disease. And I find that extremely rewarding, but I also do cytopathology still. And so I go all over the hospital to see patients and either do the aspirations myself and see the patients, or with the other doctors, specifically the radiologists often, but the gastroenterologists who may be needing to do a biopsy in somebody's esophagus or in someone's stomach. They'll stick a tube down and take a biopsy, or a fine needle aspiration was what we call a thin needle, and they'll hand it to us and we'll smear it out and we'll look at it right away. So I get to work with a lot of different doctors, and I find that incredibly invigorating, and being able to have the answer is always really rewarding. I do autopsies also. So I'm one of the only pathologists that does kind of all of the different areas of anatomic pathology, but I do autopsies with our trainees on patients who've died natural deaths. So there are forensic pathologists who deal with the patients who have died unnatural deaths, and then we do the autopsies on the patients who've died the natural deaths to help answer questions for their families and for the doctors as to why they may have died, because we don't always know what we know that someone probably died naturally, but we may not know for sure why they died. I have a lot of administrative roles too in the department. I've been kind of the head of the anatomic pathologists and that section for 9 years, and now I'm a vice chair, and I help work on the culture of the department and work through, getting us better at understanding our diversity, equity, and inclusion in the department. And I work nationally in the areas of cytopathology on national committees, similar to what Dr. Wojewoda talked about with the CAP. I work with the National Committee for Cytopathology and on diversity, equity, and inclusion. A lot of what I do is teaching every day. I'm not doing this alone. We're at an academic medical center. So we have residents and medical students that we teach while we're doing our job, as well as in the preclinical years. We teach over in the medical school, kind of the basics of disease before the students get over to the hospital. And then this is just some of the collaboration. I wanted to make sure that, we're going to talk about medical lab scientists, but we also have a variety of other allied health professionals that help us. In anatomic pathology, we have the cytotechnologists. That's a 1-year training program after undergrad to assist in cytopathology. There's laboratory assistants, and that could be almost any level of education. There's histotechnologists. Those are the people that actually make the glass slides that I look at. And then there's pathologist assistants, which is a 2-year master's program after undergrad. And several of these people in these images are the pathologist assistants that help us evaluate the organs or do the autopsies also. Here's some just images of medical technologists and some of the things or the medical lab scientists, as Kate will talk about, some of the things that they're doing in helping run the blood bank and storing cells for stem cell transplant, evaluating blood smears, evaluating other body fluids. And then this is the fine needle aspiration that I was talking about, where we actually stick fine needles into lumps and bumps and pull out almost individual cells or very small clumps of cells. And that we go all over the hospital and to different clinics to do this. And then just some of the things that I love I see pathology all day. I see things that are wrong with people's organs and body cells. And at the same time, I see fun images in the cells. And so the pup smear there is, they're actually cells from a pap smear. If people know what a pap smear is at the uterus, the place where the babies will grow and that sheds its lining every month. The cervix is the entry to that, and we have to scrape the cervix and look for abnormalities of viruses like Dr. Wojewoda looks at. So we work together on those, but I look at the cells, but here I saw a dog. And then I also actually do electron microscopy because we need that for kidney biopsies. And so that's the top image of the prehistoric bird. And then the actual dog catching the ball on the right-hand side is a tumor cell, is the large, lighter purple cell. And then the small blue ball next to it is actually a normal cell. It's just showing the difference between the two. But to me, it looks like a dog catching a ball. And for me, I do work similar hours to Dr. Wojewoda, and then do get called in a fair amount because I am the only kidney pathologist in the state. So if people have urgent biopsies that need to be read on the weekends and at night, I will come in. And here are my 2 dogs, my 2 golden retrievers that we have right now. And I do have 3 kids that I managed to have during all of this training.
Well, thank you so much, Dr. Gibson. It was great to hear from you. And next, we are going to be hearing from Kate Moreau, who is a medical lab scientist, which is different from a pathologist. So, Kate, you can take it away and start talking about what you do.
Sure. Thank you so much. So I'm glad that the 2 pathologists went first, and I like that Pam had a slide that highlight some of the MLS, which I'll go into a little bit more. But my inspiration was kind of a windy road. I actually didn't even know about medical laboratory science until I started looking for a job within a hospital laboratory, and that's when I first learned about it. But I think in hindsight, it was destined to be, because as an undergrad, I had actually started in, my first major was in marine biology. So a little connection to Dr. Gibson's story there. And I changed my mind a couple of times. And at one point I decided to major in chemistry, and I was a chemistry major for a couple of years. I always loved the hands-on piece of, the science classes I took. I loved the labs. And at one point I decided I don't want to work in a laboratory my whole life. I just had no idea what to envision. I just envisioned bench work. And so I eventually changed my major to wildlife biology. It was sort of a wildlife and fisheries biology hybrid, which was still very active and engaging and hands-on. Then I graduated and I worked as a radiochemist, so that didn't even work out. And long story short, we ended up moving up to Vermont at some point, and I learned about this field of medical laboratory science. And I thought, hey, I love science, I love hands-on work. You know, this would be a perfect fit. And the connection, I think, actually even went further back to when I was a young child, and I was diagnosed with something called Kawasaki disease. So if you want to go and Google it to learn more about it, it's pretty interesting. But I was one of the first cases in the United States to have had this disease. And even to this day, we're still not 100% sure what causes it. So working in a laboratory, being able to work to find answers for people who are sick or monitoring their health was really important to me. So I had decided to go back to school once again and kind of delve into medical laboratory science. So eventually on my windy road, I graduated from UMass Amherst in that degree in wildlife biology. And as I said, I started working as a radiochemist after I graduated. So I didn't go into forestry or natural resources or anything like that. I fell into a job as a radiochemist, which I loved. It was hands-on, but it was very isolating. And then I wanted to do something to sort of have a little bit more connection. I wanted to give back. I just wanted to have that fulfillment in my job. So I actually went back to school for a teaching degree, and I became certified in secondary science. And I taught science for a while in middle school, which was great. But then I started having, you know, I got married, I had babies, I stayed home, I did a couple of random jobs in between. And like I said, we moved back to Vermont, and that's really when I fell into the field of medical laboratory science. And so since then, since I finished that, I actually did it as a certificate because I already had a master's degree, and I didn't need another. I just didn't need another degree at that point. I finished the certificate and I went to work at the UVM Medical Center in their clinical laboratory in clinical chemistry. So once again, chemistry came back to me. I just loved it, and it was my path. And so I worked in clinical chemistry for a while. And then the nice thing about the career as a medical laboratory scientist is that there's lots of options, which I'll go into in a little bit. But I was working evening shift at that point, and I really wanted to move to a daytime position because I had young children and they were becoming school age, and I wanted to be home after school. So I eventually transitioned into a role as a point of care specialist. And what that allowed me to do was work throughout the hospital. Point of care testing is also called bedside testing or near patient testing. And so just as we do in the laboratory where we analyze patient samples on huge chemistry analyzers for that particular area, sometimes we have handheld devices that we can go from room to room and monitor things like their blood gas or their electrolytes, like their sodium or potassium. And we can monitor them during procedures if they're in surgeries. And we can also monitor them if they're being transported. So if they need to be taken by ambulance, sometimes they have laboratory testing that they can do on ambulances, or if they're on a life flight helicopter, we have instruments that can go with them so they can monitor the patient as they're in flight to their next hospital. And so I worked as a point of care specialist for a while, overseeing those programs. And then because I have the education background, I moved into another role as a laboratory educator, which meant I was responsible more so for the clinical education within the, all of the areas of the laboratory. So in addition to Christie's section, which is microbiology, there's the clinical chemistry, which I mentioned, which looks at all of the different, if you think of any analyte, if you're looking at glucose, if you're looking at someone's cholesterol, if you are looking at maybe monitoring what types of drugs the patient is on and how they're being broken down within the body, all that falls within chemistry. And then we have hematology, where we look at blood cells. So your white blood cells and your red blood cells. They look at your hemoglobin, clotting factors. So if you get a cut, you know, how quickly you stop bleeding. Sometimes people are missing things that help them to clot. And so in hematology, they're running tests to analyze what might be missing from that person. And then I think it was mentioned transfusion medicine. There was a picture on one of the slides for bags of blood. So transfusion medicine, or they call it immunohematology, shortened to blood bank, is another part of the laboratory. So as a laboratory educator, I worked with the MLS, or the medical laboratory scientists, in each area within the laboratory. And so now, in addition to being trained as a medical laboratory scientist, because I have the education background, I was able to move over to the educator side at the University of Vermont. So I'm clinical faculty, which means I get to teach. So I teach in the undergraduate and graduate medical laboratory science programs. I work very closely with a lot of clinical affiliates. So in part of the training to become a medical laboratory scientist, similar to pathologist, their rotations or fellowships that they do, although not as long or as intense, medical laboratory scientists get to spend an entire semester in a hospital clinical laboratory, learning all of the benches and all of the testing to, you know, help diagnose those diseases or screen for diseases. So I do a lot of the teaching. I work with our clinical affiliates all throughout New England, like Dartmouth and Yale and Mass General and everywhere that we send our students to. Outside of the classroom, I get to work with students in advising and mentoring. So part of that is helping them pick their classes, but the other piece is helping connect students to researchers if they want to do research, if they want to work with outside in, you know, certain industries, you know, getting them connected with people for internship opportunities. I have an administrative role similar to Dr. Gibson. I oversee the accreditation for our program. We're an accredited program, so we have to follow standards. As Dr. Wojewoda mentioned, the laboratory is highly regulated. And so any kind of clinical program is also, you know, we have all of our standards that we need to meet. And so I oversee making sure that our curriculum, so all of the classes that we teach, meet all of those standards. And then I get to do fun things like this too. I do a lot of outreach. I work with a lot of STEM programs at high schools. I work with, what is the other, I'm drawing a blank, but there's another organization that does a lot of outreach programs for sort of allied health careers, pathways that students can take. And because I'm clinical faculty, I have the teaching piece, but I also get to keep my foot in the door with the lab. So I don't work on the bench anymore as a bench scientist, but now I oversee some of the testing and I supervise. So I work with the community health centers of Burlington, which in addition to a hospital laboratory, sometimes there are smaller laboratories through doctors' offices or community health organizations. And so I manage that lab, which is a lower complexity than the hospital laboratory. But we still do a lot of the routine testing for patients coming in and having their blood drawn. And so I work with all of our providers and making sure that we're producing quality results, we're following all of the guidelines. And then I do some consulting too. So if you start out in something like medical laboratory scientist, there's so many different pathways that you can go or take as far as your career, both within the hospital and outside of the hospital, depending on interest, whether it's research, consulting, working with laboratory information systems, so that's the computer side. And depending on where you go, you'll have probably different types of work-life balances. As a faculty member, I have a 9-month contract with UVM, which means my contract starts a couple weeks before the semester starts and it ends a couple weeks after graduation in May. So, technically the summer is free for me, so I can schedule any other types of employment opportunities, both within the academic year, but also during the summer. So I have a lot of flexibility there. You can see my workday sounds a little bit short as at 8:30 to 3:30, but teaching is kind of I see it as a 24/7 kind of thing, because in addition to being in the classroom, there's always prep work that needs to be done. There's always assessments that need to be done, papers that need to be read, research for new modules that you might be teaching. And so with that, there's a lot of flexibility. And I have 3 children, so I need that flexibility to be able to, both pick them up from school or give them a ride somewhere, take them to an appointment if needed. But that means that, I make up that time, maybe in the evenings or possibly on the weekends as well. So I like that flexibility personally. As a bench scientist, you don't have a whole lot of flexibility. You can pick, or like if you apply, you can work an evening or a night shift or part-time or per diem or full-time. But as a bench scientist, you're there for the time that you're there. And it's depending on the department and the laboratory that you're at, it's just a different type of work schedule, because the nature of the work is a bit different. And so I don't know if I had a little bit more information. I think I covered everything that I had hoped to cover. So thank you.
Thank you so much. Thank you so much, Kate. It was really great to hear about that and just the different roles that all of you have. So this will be our first Q&A section, and we can start going through the questions that have been asked in the chat so far. So the first one, I believe this was for you, Dr. Wojewoda, and it's asking if your lab is part of a hospital or if it's an independent lab that takes cases from multiple facilities.
Kind of both, actually. So the lab that I work in right now is in the hospital. We are in the basement, which is usually where pathology is, but sometimes it can be different places with windows. So we're in the basement of the hospital, but we get samples from all over the state and even into New York, into New Hampshire. So the microbiology portion of the laboratory does some more complex testing. So we're one of the only labs in the state that does mycobacterial testing. So think tuberculosis. We're the only lab that does fungus testing. So if somebody is suspected of having a fungal infection, we get those samples. So we get samples from all over, but we are located in the hospital. There are commercial laboratories that just stand by themselves. They're not associated with a hospital or a clinic. And those laboratories really just focus on getting samples from all over their region.
Thank you. Another question we had was, do you ever wish you had more direct patient interaction? And this can go for everyone. Did patient interaction play a factor in your decisions on your path?
So I'll start because I know Dr. Gibson does have some patient interaction. I don't mind that I don't see patients, and that's not to say that I didn't enjoy in medical school my interactions with patients. I really did. I actually found myself almost getting too close to them. I really I would empathize with them a lot, and so I like detaching a little bit from that. This is kind of silly, but I like to say that I know my bugs are going to smell. Sometimes you would walk into a patient's room and she would be nice and cute and a little old lady, but then you would do your physical exam and her foot would stink to high heaven. And so like, I know that exactly what my stuff is going to smell like, look like. My day is relatively well planned out. So I don't miss the patient interaction. I think that the other doctors in the hospital are really my patients. So they come to me with questions, like Dr. Gibson was mentioning, and interacting with them is where I get my satisfaction.
Great, that was very well said. So another question that again, anyone can answer. Can you study pathology without seeing a cadaver? You kind of talked about this, Dr. Gibson, but saying that pathologists work with cadavers a lot to just determine how the patient died. And that the student has also heard that pathology is very focused on cadavers.
So in a pathology residency, you have to do a certain number of autopsies, yes, and you have to do rotations in forensics, but you don't have to do them after that. It is part of the training and things that we have to learn to do. And some people just absolutely love it. You know, that's, you know, they watch the CSIs and the forensic shows, and that's the coolest thing for them. For me, forensic pathology was not something that I felt emotionally that I could handle. I found it was really, really difficult. But hospital autopsies, I see differently. And it took me a while to get used to doing it. But really, one thing I think that helped me is that my dad died when I was in high school. A sudden death. He actually had to have a forensic autopsy because they weren't sure why he died, whether it was natural or not. And it wasn't until I got to pathology that I got to read his autopsy report. And I really appreciated being able to have that information as I got older to really understand, because at 17, I wasn't able to even process everything that was going on probably. And then later I was, and really saw that it was super helpful for my family to understand what risk we have for heart disease, because that's what he died of, was a heart attack. And so that really helped me with figuring out, I do want to be able to do the autopsies for the families, but you don't have to do them. Christy doesn't have to do autopsies. There's 4 of us that do them.
Well, and the other thing is both Dr. Gibson and I did both sides of pathology. We trained in both anatomic and clinical. You can do a residency in either anatomic or clinical, and those are 3 years each. And so if you are more, often if you're more research oriented, you could do a clinical pathology residency only, and then focus just on in the clinical lab. If really autopsies aren't your thing. But the pro section and doing autopsies, it's very interesting. You learn a lot. So I didn't like the paperwork part of it, but I didn't mind the pro section part of it.
Thank you. We have another question asking about, do hospitals or pathology labs ever employ people who have PhDs in microbiology, pathology, or similar fields? Or does every clinical pathology lab only employ physician scientists?
That's a great question. And so PhDs can be employed in a clinical lab in different roles. If you do a certain amount of training in microbiology, you could get credit and become a medical lab scientist in microbiology. We formerly had a PhD medical lab scientist in my lab, but you could also do my role as a PhD. So a lot of clinical pathologists or clinical pathology laboratories are overseen by PhDs. And so to do the PhD route for microbiology, at least, you would do your PhD, and then it's a 2-year fellowship in medical microbiology. I know clinical chemistry is often very similar.
Okay, thank you. Next, this is a question for Kate. As a medical laboratory scientist, can you diagnose diseases or suggest treatments?
No, but we sure do wish we could. As part of the education, it's pretty extensive, and you do learn a lot about disease, causes of disease, normal and abnormal results. So as a scientist, you can look at those numbers and more so identify if your tests are running properly or not, if there's something abnormal that flags that you might have to investigate it a little bit further. So you can't, all of the diagnostic piece, even though you're running a diagnostic test, they'll say there's a gold standard. So we do run tests that will determine whether or not a patient has a disease. But as the scientists, we're not the ones saying that. That's up to their provider or with pathologist input to diagnose, because we don't know clinically what's going on with the patient. So we can't say for sure whether or not someone has it. We can just say what the result is, or if it's positive, or what's present or not present in that result. But as part of the training, it is pretty interesting because you can often look at results, and sometimes we joke as techs when new residents come on board each year, because you start to see lots of what we call add-on tests as they're trying to figure out what's going on clinically with the patient. But we can't recommend what they do or not do. That's up to the pathologist or the medical directors who will correspond with them, or the other pathology residents too. So that's within the laboratory. There are the scientists, and then there are the medical directors for each of the areas, and they're overseen kind of differently, but they work very closely together.
Thank you so much. We have another question asking, and this could go for all three of you. Do you ever have periods of downtime in the lab? And they said like how emergency departments have no patients some days, or is the lab pretty consistently busy?
Yeah, I can speak to that just for a second, and I'm sure the others can add too. It does ebb and flow depending on the shift that you work on or the type of laboratory that you work within. Some days will get really busy. When I worked in chemistry, we often had couriers bring samples in from outside hospitals. If you're a reference lab, you constantly have a flood of samples that are coming in. There are certain weeks of the month that tend to be busier, like a dialysis week, where they get all of their treatments and lots of tests drawn at the same time. And that tends to be really busy and crazy. But when there's downtime, you're often, if it's planned downtime, you're often doing maintenance on instruments. It's a lot of troubleshooting in the laboratory. So you might not be busy working on patient samples, but there's often lots of other things that need to be done. But sometimes if you're working a midnight shift, it might be pretty quiet unless, something happens, or, the ED gets busy, or middle of the night patients get drawn. So I think that's kind of an all depends, my answer.
Great. Did Dr. Gibson or Dr. Wojewoda, if you want to add anything? If not, we do have another question.
Just quickly, yes, I agree. Although I think Dr. Gibson and I would agree that the past 2 years, it felt like there hasn't been any downtime. So so we got a new computer system, and then COVID, and then there was the cyber attack at the hospital. And so there's just been a lot recently. And so I think we are looking for those little downtime moments just to take a breath, and then we get to work on some of the other fun stuff that we do as part of our jobs.
Great. Okay, so another question is, can you talk more about what pathology residency is like? Is it spent mainly in laboratory working directly under one senior pathologist, or are you shifted around a lot of two different labs?
I can start with that. Yeah. So residency is like an apprenticeship. And in a residency, you rotate in the different areas of the laboratory, and you work under different physicians while you're in different areas. So now it's 4 years, like Christy mentioned, to do both anatomic and clinical pathology. And essentially you're going to be doing 2 years of each, but you will do a rotation. Maybe you'll do 2 months in a row in one area of the laboratory, and then you'll switch to another area. So it's a constant new learning all the time. And you're working with different faculty. Obviously, in microbiology, there's 2 microbiologists that our trainees will work with now. In anatomic pathology, we have 20 different pathologists. So depending on where they're rotating, they'll have, me one day, someone else another day, that type of thing. So they get to work with a lot of different pathologists over that 4 years.
And it depends on the residency program. Some of them you do anatomic pathology for 2 years in a row. So you're cutting the tissue, looking at the glass slides, making the diagnoses. And then you do clinical pathology. So rotating through the different sections of the laboratory for 2 years. Our program, it's all interspersed. So you do a different thing every 4 weeks, but you're building on the knowledge that you've obtained the first time around. So our residents spend 4 4-week blocks in microbiology, and they progress as they go, but it's all kind of split up. And it's usually all in one building or hospital system. It's not like you travel all over a city or town.
Perfect. Thank you so much. And so if anyone else has any additional questions, continue to put them in the chat. And we'll be able to address them in a few minutes, but we are now going to walk through a really interesting case study. So I'll let you take it away.
Okay, I can start. So I really this was a case that Christy had and I had worked on, and several medical laboratory scientists. And so we thought it would be a good example of how we all work together and work with our clinical colleagues. So this was a patient that we have that we saw and were able to write up this case because it was very unusual. This was a young woman who presented with some nonspecific symptoms and went to her doctor. The doctor got some images and found that there was a liver mass as well as a lung mass. And with those masses that were seen, and you can see in the image on the left is pointing out the liver mass, and then the image on the right is pointing out the lung mass that were discovered when she had the radiology exams. And when we see masses like this, especially in 2 different organs, we're really concerned that this could be a tumor, a malignancy. And so the patient initially had a biopsy of the lung mass, and that revealed pathology, but it was not a cancer. It was the pathology of an inflammatory reaction that we often see with infection. But that same inflammatory reaction can sometimes be seen with cancer, but they couldn't find the cause of it. It was just the inflammatory reaction that came out of that biopsy. So the doctors were still really concerned that she had cancer. So they decided to do a biopsy of the liver. And I was there for that biopsy because, as we said, I go to radiology to assist on these biopsies with our cytotechnologists and our trainees. And so we did the biopsy. And I knew the results of the first biopsy that was this inflammatory reaction. And what I started seeing made me believe that this could still be all an inflammatory process, not a cancer. And so when we brought the samples back to the laboratory and stained them, the next day when I was looking at them, I found structures that were in the inflammatory reaction that did not look like they were part of the human body. I mean, I've studied probably every cell in the human body and what it looks like, and these are not human, but they're not a typical organism that we see, a typical bug, as Christy likes to say, that we see every day. They're much larger, and in this image you can see On the left is kind of a pink and blue stain that we normally do on the tissue section. So this is a microscopic, an image of a microscopic section. And there are some white structures with a pink lining around them. And those are the abnormal structures. And then on the top right, you see these dark outlines. And then on the bottom right, you see kind of a purple outline. Those are the structures stained with different stains that we do. And these are stains that normally do stain bugs. And so they're staining, but they're much larger than what we normally see for a bacteria, much larger than a bacterium and much larger than a typical fungus. So I then brought them to Christy because I was very concerned that they could be a parasite.
And because I trained in both anatomic and clinical pathology, I do get to look at tissue slides when there's a concern for infection. And I agreed with Dr. Gibson that this didn't look human, and it didn't look like any of our normal infections. And so it looked like it could be a parasite. I was definitely thinking that seemed correct. And we discussed it with somebody who used to be a resident at UVM, who I work with on one of my committees. And she also agreed that she thought it looked like a parasite. And so we wanted to make sure that the patient was appropriately taken care of. So we contacted the doctor that did the biopsy, and we asked them to do some testing of their blood to look for exposure to different parasites. And then we really wanted to make sure that the patient was being taken care of by an infectious disease specialist, somebody who really would be able to narrow down what, if this is a parasite, what parasite is it and how do you treat it appropriately? And so then the patient was seen by a medical lab scientist.
So we had sometimes, depending on where the medical laboratory scientists work, phlebotomy is part of their job. So in some hospitals, they'll actually run upstairs and draw the blood and then run back to the lab and test it. So in this case, they had called a phlebotomist in because there was some blood test ordered. So the phlebotomist went ahead and obtained whatever they needed. There's different types of containers that you would draw blood into depending on where it was going in the laboratory. So this patient needed some serology tests, which meant we wanted to look for particular antibodies. And so after the phlebotomist draws the blood, they send it down to the lab. It goes through specimen processing and receiving. So they'll distribute it to whichever laboratory department will do the testing. And in this case, the infectious disease doctor did a very thorough history and physical, and still wasn't sure what we were dealing with here, but the serology test identified antibodies to this Echinococcus bacteria. So from there, I had to go on to identify what type of antibodies exactly they were.
So to do that, because we couldn't tell for sure just based on what that looked like, sorry, but we knew that the patient had been exposed to this Echinococcus organism based on the fact that they had antibodies to it. And it's not something that all of us have been exposed to, so we wouldn't have our bodies would not have produced antibodies to it unless you'd been exposed to it. We wanted to make sure that this material that was in these biopsies was actually the Echinococcus organism. So we needed to send the tissue that we still had that we preserved from the tissue sections that we made and looked at under the microscope. We sent that off to actually the National Institutes of Health and to colleagues in Switzerland and Germany who were able to do additional PCR testing to identify the actual organism and prove that this was an Echinococcus organism, and it's called Echinococcus multilocularis, which is actually an unusual parasite. It's more common in Europe and has been more common in Canada of late, but pretty uncommon in the US. And it does it's a parasite that gets into the blood system, and it can make it look like someone has a tumor, but it's really that it's the damage that the parasite does that damages the organ itself and causes a lot of inflammation and reaction to it that makes it look like a tumor, but it's not really a tumor, it's a parasite. And so with all that identification, they were able to begin treatment and start treating the patient. That is kind of our summary of how we kind of work together to figure out this unusual organism.
Thank you so much. And so we can take, just one quick question. So how can one get exposed to Echinococcus?
Yeah, so this particular Echinococcus can be carried in foxes. So it's carried in other species and other mammals, and then the humans get exposed either by the feces, the urine, or potentially eating the meat of another animal.
Perfect. Thank you so much. And then we have just this additional aspects of pathology and medical lab sciences. If any three of you want to touch upon just extra things you like about your job, and then we also have extra time for a Q&A at the end. So if anyone has any questions, please put them in the chat.
I guess I can just add one more thing. Sorry. And I like the slide. It's a nice summary of everything that we kind of touched upon. One of the things I love about medical laboratory science is that every day is different. You never know what you're going to see. You never know, what kinds of scenarios or what's going to happen with the instruments you're working on. And even though we're the behind the scenes, because we don't see the patients, we're touching every patient, literally. We process all different types of specimens, from blood to cells to tissues to you name it, fluids, different kinds of body fluids are being processed, all to try and figure out either what's going on with the patient, or monitor them if they've been diagnosed with something, or screening, just to ensure that they're staying healthy and, keep doing what they're doing. Because it's not always just being sick. It's a lot of monitoring too, to make sure that people are just, keep on doing what they're doing. So it's in thinking about, do I wish that I would have, been more at the bedside or more present? I feel like doing this, you work with so many more people in a way, because you're processing so many more samples. At the medical center, it's millions of tests per year. So each one of those tests is a patient that you get to work with in a way. And so it's rewarding in that sense, and making sure that we're giving them the right answer that they need. So I love it, but I'm totally biased.
That was awesome, Kate. Yes, my techs really in the lab, they're taking care of that patient, that they're looking at their plates or they're running their PCR. They really want to take as good a care of that patient as they can. Something else that I was thinking about that Dr. Gibson brought up a little bit is that pathologists often are leaders in the hospital. So Dr. Gibson mentioned her administrative roles in the department. Again, I am managing a team of 35 medical lab scientists that do the work of the testing. But we also run hospital committees. We've had former pathologists who were the head of the medical staff. So part of a role of pathologist often is administrative work and being a leader in their department, their hospital, their network. So that's another really cool part about pathology that not a lot of other specialties get to do. So there's more managerial roles, and that's kind of fun too.
Thank you so much for sharing. And so we'll now move on to our final Q&A. One of our questions is, are there board exams for pathologists?
Yes, some of the toughest ones I've ever taken. So after residency, there are board exams for the medical lab scientists. They, to get certified, have exams. The pathology exams are 2 days worth of exams now. They were 3 days when I took them. Thank God they're only 2 now. But it's a long 2 days, and then you have to do continuing medical education and actually do testing like almost constantly, it seems, over the rest of your career. It's a continuous process. You can't stop doing it to continue your certification.
Okay, great. And then another question we have is, what do you do if everyone in your lab is stumped on a certain test result or diagnosis? Is there anyone that, the attending pathologist could consult if you're really just getting stuck on something?
Well, like in the case that we talked about, we showed it to our colleague who is now the head of parasitology at Mayo, who had seen 2 cases of this as a parasitologist. She had seen 2 cases in the past that came from Canada. So she was able to help confirm it. And then we were able to, employ the help of the National Institutes of Health and colleagues in Europe who had seen more cases. So now that the world is so much smaller, especially, we can reach out so quickly, so easily to share our glass slides. Our images of our glass slides can be sent electronically, and people can help look at them and give their opinions. So for this case, it was a great example of something that we have not seen in the Eastern United States in years, and that I'd never seen before. But had read about and had a feeling this could be it. But we're able to consult throughout the world.
How often do you see really rare cases like that?
Not every day. I've been doing it 30 years, and it's the first time I've seen this, obviously. But there are rare things that but common things are common. A good portion of our day is the common thing, but you just have to be alert to something that's going to be unusual. And that's part of staying abreast of new literature and keeping up your credentialing. So what new things are evolving.
Great. And another question was, how long does it usually take to obtain results or, come to a conclusion about a particular diagnosis or something? Because I feel like just from, getting my own blood drawn, that it can be a decent amount of time, but what's like the average timing?
It's hard to give an average. So for a blood test, you can get certain blood tests within a couple of hours. Organisms that we're going to try to grow, Christine can talk about that. You got to wait for them to grow. They actually have to divide, right?
Yep. So some of our cultures take 4 weeks for mycobacteria, for example. But then there are other tests that we do that, are an antigen test in 15 minutes or a PCR in an hour. And then when Dr. Gibson's looking at slides, it's really how complex is it? Is it very common and a quick diagnosis versus something that's really complex and haven't seen it before and have to ship it all over the world that could take weeks.
Yeah, most tissue biopsies, if it's just a biopsy, should take about 5 days from us receiving it to doing all the processing and getting out the report. But if, as Dr. Wojewoda said, if it was more complex, it's going to take longer. If it's a large resection, if someone has to have, a big portion of their colon taken out or their liver or something, that's going to take more time to analyze that. My kidney biopsies take more time because there's even more complex testing that we do. So the electron microscopy part of it takes even longer. So it has a portion of the sample I will look at under the regular light microscope, a portion I have to look at under an immunofluorescence, using a fluorescence microscope, and then a portion I have to look at under electron microscope. So, it can take 2 weeks to do all that.
Thank you.
Yeah, and
Oh, go ahead.
Oh, sorry. I was going to add for the other areas of the clinical lab, it's less manual, meaning that, there's not as much microscopy. So the turnaround time for more routine tests tend to be a lot quicker. So the only variation there is if it's something that's not routine, where it might only be tested, a couple days a week on a particular analyzer that is used, or a certain bench that's only run, only infrequently because of maybe the volumes of those tests are kind of low. But for routine testing, you'd be surprised that some of the tests take 20 seconds to run, because we just have to do so many of them on a daily basis that if you're running thousands and thousands, you can't wait that long for them. It used to be the case, but not anymore. So routine testing, you could maybe after the doctor reviews it, if you have to wait for those results to be released, but when they get to the lab, it's usually pretty quick.
Yeah, and I was just going to mention, now with the 21st Century Cures Act, there's a requirement that we release patient results to them as soon as they are ready. And so those results will show up if you have a portal of some form, as soon as they're done. So that will cut down on some of that time to patient notification.
Thank you. And just going off of that, it seems like you do such a wide variety of things. This might be a hard question to answer, but how many different tests would you say you do in a day in the lab? If you're able to answer that.
Oh, that's tough. I'd say we do at least 50 different tests in microbiology, just different cultures, different types of cultures, different PCR assays, different spot tests. And then we also do parasitology, so looking under the microscope at stool and blood for parasites. So I would say probably about 50 in micro. But in clinical chemistry, it's a lot. And immunology is all the different serologies. Yeah. Pam, when we were doing like the Beaker CCV, was there an overall like test build number?
No, it's like Kate mentioned, we do over 2 million tests a year in the laboratory. So, I mean, if you think about it, break it down by day, I mean, there's, and they're not different types of tests. It's just all the testing we do. So, I mean, there's probably over 1,000 different tests that we do on a daily basis, I would think. I don't,
At least. I think in the test catalog, which some of those probably include send out. So those are ones that would be sent to other laboratories like Mayo if we don't do it, but we'll kind of carry it on its way. I think it was something like 4,700 different tests that were available, which is crazy and kind of confusing too. There, it's great that there are lots of tests, but they have different utilities, and that's where those conversations with other clinical colleagues becomes really important to make sure that people are ordering the right tests for the right diagnoses for whatever it is that they're looking for. There's a lot.
Thank you. And then just one final question. I know some of you touched on this a little bit, but how did the pandemic really impact pathology and medical lab sciences, and how did your jobs really adapt to it?
And again, Dr. Gibson and I are going to have different answers here. My job really from the beginning of March of last year all the way until I would say March of this year was just focused on getting more testing faster. And that was really difficult when there weren't supplies. We couldn't buy more test kits. They didn't exist. The plastics industry was wiped out by this. So we couldn't have pipette tips to run the testing. And then making sure that we used our precious resources on the patients that needed them the most. So we hired, I think, 3 or 4 people just to aliquot samples. So taking some of the sample from the primary tube and putting it into the tube that it needs to be in to be tested. We hired 2 more staff in the genomics laboratory that runs the high throughput assay. The micro lab staff were out flat working on COVID samples. But on the other hand, we shut down the ORs for a period of time and only did emergency things. And so that impacted Dr. Gibson's work, but that also impacted some of the other sections of the laboratory and some of the routine testing in microbiology. Those volumes decreased actually. And so we're just kind of getting now back to the point of normal, at least in microbiology. And I think things are on the upswing up in Pam's area.
Yeah, absolutely. Yeah, and because, you know, the hospital had to limit the number of patients and the exposure and everything, that, as Christy said, that routine visits were not happening. So we get a lot of colonoscopies, screening for colon cancer in a typical day. They couldn't do those. A lot of people go see their dermatologist and get skin biopsies. They couldn't do those. So the volumes of those went down, but patients who had, you know, really significant severe cancers still had to have surgery. So we still had those, but very little of the routine material coming in. So it definitely altered what we did and how we did it. And now we're above volumes from before. You know, it's definitely picked up.
Okay, so we have just 2 more questions that we can quickly address before we run out of time. So the first one is, how much PPE do you need in your lab for all 3 of you?
So I can just talk about for anatomic pathology. You know, we have the possibility of significant exposure because we have fresh tissue and at autopsy in particular. So we have to, you know, be, you know, in full PPE really when we're dealing with the fresh tissue. So masks and face shields and gloves and arm covers and, you know, special gowns, and in the morgue especially, we have to have, you know, even, you know, more importantly, the type of airflow in the room has to be very specific in some of our rooms. And so it's not just what we have on ourselves, but it's the room itself has to have be made specifically to handle potential infections. And Christy can talk more about that.
Yeah, and so in microbiology, it varies based on the testing that we're doing. So when we're working with direct patient samples, we're always under a hood, a biosafety cabinet. And so gloves are the only PPE, and a lab coat are the only PPE that's used for direct patient sample handling. Bacteria, they stay on the plate for the most part. And so when we're looking at bacterial cultures, it's just a lab coat, no gloves or mask or eye protection. The highest level of PPE that we use is when potentially working with tuberculosis. And so when we're doing those types of cultures and samples from those patients, it's a special gown, gloves, an N95 mask, and eye protection. And so when the techs are reading those cultures, that's the highest level of PPE. But I was very upfront with my staff for with working with COVID samples, our policies and procedures for working with patient samples didn't change throughout COVID. It was because we use universal precautions, which is when we're working with a direct patient sample, it needs to be contained in such a way that we couldn't aerosolize anything. And so all of the COVID samples are handled under a biosafety cabinet, just like all of our other samples. There's no extra PPE required because we have safe practices throughout.
And for the other areas of the laboratory, very similar to microbiology, it's universal precautions. You treat every sample as if it could be an infectious agent in it, because you don't know if there's other bloodborne pathogens if you're working with blood samples. And so, most of the time it's contained because you're working on a lot of instruments or you're working with something that's mounted on slides. So you're just wearing gloves and a lab coat the majority of the time. But if there's any kind of splash, if there's any like potential for splashing something in your face or your eyes, then, goggles, face shield are definitely warranted. And then for, depending on the level of the laboratory, if you're a biosafety level 1, 2, 3, or 4, the PPE will change for that. So the other laboratory that I work with, which is considered a moderately complex lab, we actually don't even have any hoods because we're not handling anything that warrants that those samples are sent over to the hospital. So that kind of determines to what level of PPE. But because of COVID, we were in small spaces. So, everybody took those precautions because techs tend to, not that they're on top of each other, but they work very closely together.
Well, thank you all so much for being here. It was so incredible to hear about all of your stories and your jobs and the wide variety of things you do. So thank you so much for giving us your time tonight. So again, thank you everyone for joining us and for such great questions. We really appreciate the engagement. And for next month, which will be again on the 4th Thursday of the month, back to our normal timing, we are going to be spotlighting nurse educators, and we'll be joined by Terry Cahill-Griffin and Melissa Stewart, who are both RNs. So please join us again next month on August 26th to be discussing that. And again, thank you so much for joining us, and enjoy the rest of your nights, everyone. Yes, thank you. And follow our Instagram at BT Reach, where we continue to post information about our upcoming sessions. And you can share our YouTube channel, which has all our sessions recorded on them. Yep. So we'll see you all next month. Thank you.